All right, so Deputy Attorney General Ward, would you mind explaining Ms. Lee's role as the presiding officer?
Good morning. For the record, Harry Ward, Deputy Attorney General. This subcommittee can have a chairperson or an acting chairperson. I think Ms. Lisa Lee will be doing that. We do have a quorum. May I remind everyone to just remember to state on the record who you are. This matter is being recorded under the open meeting law. We will go through the agenda. We'll do a roll call. We'll follow the agenda. And if there's any questions, anyone can interrupt. But as per, I think Rosalie Bordelon sent out an email that it's perfectly all right for someone else to chair this meeting. So if anyone has any questions, just chime in.
All right, and Kelly Marshall, for the record, we do expect Chair Thomas. She just had an appointment this morning. So Ms. Lee.
Good morning, everyone. I'd like to thank you for joining us all today and welcome you all to the October 25th, 2022 Substance Use Response Group Treatment and Recovery Subcommittee meeting. And I'll turn it over to Ms. Marshall to call roll. It is 9:03 a.m. and we'll call this meeting to order.
Right, this is Kelly Marshall for the record. Assemblywoman Thomas. Chelsea Cheatham.
Present.
Dr. Leslie Dixon.
Here.
Mr. Jeffrey Iverson. Ms. Lisa Lee.
Present.
Mr. Steve Shell.
Present.
Madam Presiding Chair, we have a quorum.
Wonderful. So we'll proceed on to agenda item number 2, which is public comment. Public comment will be received via Zoom, and you can do this by raising your hand and unmuting yourself when you are asked for public comment. Public comment shall be limited to 3 minutes per person. No action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda item upon which action may be taken pursuant to Nevada Revised Statutes 241.020. So if you'd like to speak, go ahead and raise your hand so that we can see you and unmute yourself and state your name for the record. Thank you.
So, Madam Presiding Chair, I do not see any hands raised. I do not see anybody connected by phone. And I just would like to note for the record, this is Kelly Marshall, and Assemblywoman Claire Thomas has joined the meeting. Ms. Thomas, would you like Ms. Lee to continue as presiding chair for the time being, or would you like to take over those duties?
No, she can continue for time being. I just want to make sure it was going on. Sorry about that, but I'm still in the office. All right, okay. So I'm leaving the meeting again.
Okay, thank you. All right, so Kelly Marshall, for the record, let's let the record show that Ms. Thomas has joined the meeting and is now leaving the meeting, and we still have quorum. Okay, so in that interim, I still do not see any public comment.
All right, well, thank you. And just as a reminder to the public who are joining, we do have an additional public comment section at the end of this meeting. We'll move on to agenda item number 3, which is our approving our minutes. I hope everyone had time to review those minutes from our September 23rd, 2022 meeting. And I will open the floor for any discussions or any corrections that may need to be made before we have motions on the floor. And just as a reminder, if you're not speaking, can you please mute your mic? We're getting some lovely music. All right, well, I actually do, this is Lisa Lee for the record. I do have a proposed change on page 7 of the meeting minutes from September 23rd. The record currently says, let me find it here. It says opioid rehearsals. That should be opioid or overdose reversals, not overdose. It's right at the second line there. It says many opioid overdose rehearsals. If that could just be changed to reversals.
Kelly Marshall, for the record, duly noted.
Are there any other corrections from the members? Hearing none, I'll entertain a motion to pass, to accept these meeting minutes.
This is Steve Shell for the record. I make a motion that we approve the minutes from the September 23rd subcommittee meeting with the changes noted by Ms. Lee.
And this is Chelsea Cheatham. I second that motion.
We have a motion and a second. All in favor, please indicate by saying aye.
Aye.
Aye. Any opposed? Any abstentions? All right, motion carries unanimously. We'll move on to agenda item number 4, which is.
For the record, Harry Ward, Deputy Attorney General, just a quick, so the record reflects, it carries unanimously with those present.
With those present. Thank you, Mr. Ward. All right, moving on to agenda item number 4, which is finalizing our subcommittee recommendations. And I'll just read from this because I wasn't part of this as a chair, and let the record reflect that. It says, we met with the full SURG committee on October 4th and presented our recommendations to the SURG. Some suggestions were made by Vice Chair Tolles for synergy with other subcommittee recommendations. Today, we are going to review the recommendations you made, changes made by the prevention subcommittee, and share the justifications, resources, and options for implementation. We will go through the recommendation by recommendation, and Ms. Marshall will highlight where we may choose to revise a recommendation and ask you to provide implementation options. This is agendized as an action item, and we will use the process we used in September and ask for motions after each recommendation. So we'll move on to the next slide.
So Madam Chair, Kelly Marshall for the record. So we do have the option that you could hold the motion till the end of all discussion, or take it recommendation by recommendation as we have on previous recommendation review. Just to start, your recommendation is the recommendation listed under number 1. That was your number 1 recommendation to the SURG. The prevention subcommittee met on October 12th, and they revised a recommendation that they had, which was to promote telehealth for MAT, considering the modifications that have been made under the emergency policies. And then they took your recommendation wholesale and added it to their recommendation to expand the recommendation. So the subcommittee can determine that you want to retain your recommendation as is. You could adopt the same recommendation as the prevention subcommittee, at which point I think they would just be merged together. And it's important to note that recommendations in the report will not be listed by subcommittee. They will be listed as recommendations from the SURG as a whole. The other option is you could drop that recommendation if you felt like it was adequately covered. But those are the recommendation options that we spoke through, and I would turn it back to Madam Chair Lee to start the discussion.
Thank you, Ms. Marshall. Lisa Lee for the record, and let's open the floor to discuss this. What shall we do?
Dixon has her hand raised, Madam Chair. Kelly Marshall for the record.
Dr. Dixon.
Dr. Dixon, I don't think I like that being the lead sentence, promote telehealth. We have it in there later in the thing. So I think expanding access is really what we want to say, not promote telehealth. Telehealth should be used under, under circumstances that justify that, but getting mapped out to everybody seems to be the bigger issue. So I'm not sure I like the lead sentence in our number one response, our number one recommendation that promoting telehealth is the lead sentence. And if you want to hear my as a provider, physician, why I'm a little bit reluctant to make too big a deal for telehealth for Matt, because I feel very strongly that if at all possible, we should see these patients in person. And where I work, we only do telehealth when there's an illness or something like that that's getting in the way of doing in person. But folks that are struggling with substance abuse, they need the attention that a live interview can provide, if at all possible. So that's my thought.
Thank you, Dr. Dixon. Lisa Lee for the record. Am I just able to respond to that? Okay, great. So just as a committee member, Lisa Lee for the record, I really disagree with not including telehealth. I feel that the emergency provisions that have expanded access via telehealth have been paramount. I read article after article about this, and that emergency provision will go away at some point. And that expanded access that has been provided through telehealth will go away, especially for medications used for opioid use disorder. This has been a critical piece to expand treatment access for so many people that have sought treatment. And I will tell you that I do refer a ton of people to telehealth providers that offer either exclusive telehealth services, MAT services, or hybrid options for people. And people are much more open to that because they're able to retain, their employment. They can just do their appointment on their lunch break. They don't have to get childcare. It really removes so many barriers to engaging with treatment. And so I just wanted to offer that dissenting observation. And I see Chelsea has your hand up. Chelsea, go ahead.
Yes, so I agree with Dr. Dixon about removing that first sentence that promote telehealth and kind of staying with our original recommendation. I don't think that telehealth should be the focus of it, but I love the fact that telehealth is included in our recommendation. And Lisa, I know that you mentioned kind of that hybrid option. I'm not sure, maybe we want to add that, so including use and promotion of telehealth or hybrid options for MOUD treatment. Just as someone who worked for an organization that provided that helped set up MAT treatment in rural areas, that telehealth was so important in helping people to be able to see not only their provider, see counselors. So I completely want this to be our first recommendation. I think it's a really strong one, but I think if we remove that first sentence and kind of stick with our original recommendation, it covers what we wanted to focus on.
Thank you, Chelsea. Lisa Lee, for the record, I do see that in our original recommendation. I just want to state that it says including use and promotion of telehealth in there. I think the ask is, do we want to retain our original, if I'm correct, if I'm understanding this correctly, Kelly, do we want to retain this recommendation given the fact that another committee, the prevention subcommittee, made the recommendation on the bottom, which is largely consistent with our recommendation? Do we want to sort of duplicate recommendations? Do we want to weave them into one? Or do we want to be able to tackle a different recommendation from our list in lieu of this one? Is that correct, Kelly? That's kind of what the ask is.
Kelly Marshall for the record. Yes. So as it stands right now, the recommendation listed as recommendation number 1 is what was presented to the SURG. The recommendation bullet pointed below largely reflects your recommendation. It pulls out the including use and promotion of telehealth, considering the modifications that have been made under the emergency policies, and adds promote at the front. So it actually appears twice in the prevention recommendation. And so your options really are to revise recommendation 1 in whatever way you see fit, or to retain recommendation 1 as written, or to say that you agree with the promote telehealth recommendation from the prevention subcommittee. So
It's Dr. Dixon again.
Go ahead, Dr. Dixon.
Okay, I just want to say something about this, the thing about the emergency policies. You know, CMS and SAMHSA both promote, are in, not promote, that's not the right word. They are pretty much adopting policies to continue telehealth after the emergency is over. So I don't know that we even need to do this. This is really, once CMS and SAMHSA say this, and they already have, and it's really, we don't even really need to, I don't think, I may be wrong, but I don't think we need to consider the emergency aspect any longer. This is just going to be, I think, become standard medical, accepted medical care. But I'm going to move that we go with our original verbiage.
So we have a motion on the floor to accept our original recommendation.
This is Steve Shell for the record. I will second that.
We have a motion and a second. All right. I would like to proceed with voting on each one individually, if we can. So
For the record, Harry Ward, Deputy Attorney General. Madam Chair, that's perfectly all right. You have control of the gavel. Once we have the second, just briefly open it up if there's any further discussion, and then move on for a vote. Thank you, ma'am.
perfect. Thank you, Mr. Ward. Is there any further discussion on this item? Well, hearing none, let's move it towards a vote. All in favor, please signify by stating aye.
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 I believe I heard all 4, but I'm going to go ahead and ask for, is there anyone opposed? Please indicate by stating nay. In any abstentions? All right. This motion carries unanimously to accept our original recommendation as written. And we will move on to,
For the record, and it'll be just, we don't have to say anymore, unanimously with those in present.
with those present. Thank you, Mr. Ward.
So, Madam Chair, this next slide relates to that first recommendation. And this pertains to what will go into the Kelly Marshall for the record. This pertains to what will go into the January report that will be provided as described to the parties listed in the legislation as it was passed. And so there is a section after each recommendation for us to provide justification, action steps, and then research links that reinforce why this recommendation is considered evidence-based and important to implement. So in terms of the justification, you can see that the treatment approach has been shown to improve patient survival, increase retention and treatment, decrease illicit opiate use and other criminal activity among people with substance use disorders, increase patients' ability to gain and maintain employment, and improve birth outcomes among women who have substance use disorders and are pregnant. And that is from SAMHSA's guidance related to medication-assisted treatment. There are additional research links below, specifically to the Emergency Department Bridge program as well. The action steps were provided by the Prevention Subcommittee action steps. So what they suggested were policy changes so that MAT can be delivered via telehealth, expenditure of settlement funds to enact those recommendations, and requiring DHHS to revise reimbursement rates and utilize expenditure funds to match the national average reimbursement rate for services. So I have provided those to you from the Prevention Subcommittee because they pertain exactly to the recommendation you just made. And for today's subcommittee, we are also looking to build out the action steps. So for some recommendations, we do not have action steps, but this was considered to be a working meeting so that you as a subcommittee could provide action steps that you felt would be most pertinent for implementation of the recommendation you are making. So that's why we are taking the recommendation first, and then we're moving to the action steps. And I think the question would be whether anyone has any additional justifications they would add, any additional research links they would like to provide. But the primary purpose for this slide is to see if there are any additional action steps that this subcommittee would like to recommend in the report.
Lisa Lee for the record. Thank you, Kelly. And we'll open up the floor for any discussion related to the justification action steps and any kind of research links that would be helpful to include. Dr. Dixon,
Dr.
please.
Dixon, the only thing I would like would be to see an inverse put C at the top, because if we don't get this fixed, it doesn't really matter about the rest of it. So the reimbursement rates are so bad that I don't know what the national average reimbursement rates are, but yeah, they're so bad that, you know, a lot of folks just can't do this kind of care because they can't keep an office open with the kind of money that Medicaid and Medicare provides for it. So that's just that's the only thing I have to say. Yeah.
Thank you, Dr. Dixon. So just Lisa Lee for the record, so just for clarification purposes, you're advocating that we move item C from the action steps up to the A position. Is that correct? To sort of highlight that as,
Right.
Yeah, I would agree with that.
Madam Chair, Kelly Marshall for the record. So what you will see on subsequent slides is that we're actually categorizing things under policy, funding, other categories. So it will end up being placed in the category of funding or legislation. But for our minutes, we can certainly raise that up to item A and move A to B and B to C.
Thank you, Ms. Marshall. That sounds great. Do we have any further comments on this piece of it?
Madam Chair, this is Steve Shell for the record. I just wanted to question number A when it relates to, when it mentions policy changes. I know if CMS and SAMHSA are really the overarching, authority, I don't know, do we need to explain a little bit more detail about what these policy changes are or where they they live within our state. I don't know, that just stood out to me. So I just wanted to bring that up to the group for discussion.
Thank you, Steve. Lisa Lee, for the record, as far as I know, that has not, those may be recommendations from CMS and SAMHSA, but they are certainly not policy yet. And so there has been a lot of buzz within the MAT community around, will those be retained when that public health emergency ends? It keeps getting extended. And so, you know, policy things can change, as we've seen within the last week with student loan forgiveness and then the court sort of blocking that. So without it being set in stone, you know, there's a precarity there. Unless Dr. Dixon knows more on that.
Just what I read, Dr. Dixon. That's why I think there is, CMS can kind of act on its own to an extent. And but I don't know how definite it is, but most of what I read seems to indicate that's the way it's going to go. Later, well, actually early in the next year, we'll be meeting with the former head of SAMHSA, and maybe she can shed some light on where things really are.
Thank you, Dr. Dixon. Lisa Lee, for the record, again, I just also know that Nevada tends to align our policies with things that are happening at the federal level, that are not, I mean, there is often incongruence between our NRS and NAC and what happens at the federal level. And so I know that a lot of our legislative sessions are spent kind of trying to align our state policies with those federal policies. CAPTA and CARA, for example, of 2016, and then with our 2017 legislative session. So so I just want to advocate that it sort of does need to be on our policy you know, radar, that we're moving forward in our state to sort of align and make those recommendations concrete. Thank you. Kelly.
Thank you, Madam Chair. Kelly Marshall, for the record. Just to note that because we do not know how SAMHSA will, or CMS will enact that policy, they may make it an option for states, in which case the state may be required to do a state plan amendment in order to avail themselves of that option. And so I think that's just something to note, that there is an unknown that may in fact reinforce the need to support policy changes so that MAT can be delivered via telehealth in Nevada.
Thank you, Kelly. Do we have any further discussion on this item? Or any motions to accept the justification, action steps, and research links to include with the previous recommendation?
This is Chelsea Cheatham. I motion to accept the recommended justifications, action, and research links.
Steve Shell, for the record, I will second.
Wonderful. We have a motion by Chelsea and a second by Steve. All in favor of accepting the justification, action step, and research links for the previous recommendations, please signify by stating aye.
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 Any opposed? Any abstentions? And let the record reflect that all members present, it was unanimously passed, and we'll move on to the next agenda item.
So Kelly Marshall, for the record, Madam Chair, item 2 or recommendation 2 was to engage individuals with lived experience in programming design considerations. It was noted in the October 3rd SURG committee, actually the response subcommittee recommendation from October 3rd, that they wanted to leverage existing programs and funding to develop outreach response providers and or personnel that can respond to any suspected overdose and offer follow-up support, referrals, and services to the individuals and loved ones following an overdose. It goes on to say that providers and or personnel to be deployed to anyone being released from an institutional setting who is being discharged post-overdose or suspected overdose. Madam Chair, it was noted by Assemblywoman Toles that she thought there was alignment between our recommendation and the response recommendation. However, in having been present for previous treatment and recovery subcommittee meetings, my understanding was that our recommendation was broader than specifically talking about outreach and being present and deployed during an overdose. And so we wanted to bring this back per Vice Chair Toles' suggestion at the SURG meeting for consideration.
Thank you, Kelly. So we are looking at two vastly different things here. One is engaging people with lived experience in programming design considerations, and the other one is for post-overdose response, which is gaining traction across the country, but is a very specific intervention. Let's open the floor for discussion around this.
Okay, I just, is
Dr.
this
Dixon.
something that was, yeah, Dr. Dixon, for the record, was this something that's in their recommendations?
So
So,
Kelly Marshall, for the record, the response subcommittee, so your sister subcommittee, made this recommendation at the SURG committee, and Assemblywoman Toles, serving as vice chair, suggested that there may be alignment or a way to integrate those recommendations. So we are bringing that for your consideration. That does not mean that you are required to take any action. You could retain your recommendation as is. You could expand it in some different way. We are just bringing that back for your consideration per the discussion at the SURG subcommittee that recommendations would be brought back to the subcommittees to see if there were ways to integrate or align them.
Chelsea Cheatham, for the record, I find that the recommendation that we have is completely different than the other recommendation. So I don't think that we should combine them or select their recommendation over our second recommendation.
Thank you, Chelsea. Lisa Lee, for the record, and I completely agree with you. I think these two are not aligned, other than, yes, you could use people with lived experience on post-overdose response teams, but to me, they're two totally different things as well. Steve?
Steve Shell, for the record, I totally agree. I think these both statements are completely separate, completely different. So I would leave our recommendation as is.
So at this point, we may be ready for a motion.
Madam Chair, this is
All
Steve.
right,
Shelf for the-
also move. Also move that we leave our recommendation the way it is.
All right, Dr. Dixon, and I bet you have a second, maybe, Steve.
I do. Steve Shelf for the record. I will second that.
All right, I thought you were gonna have to Rochambeau for that. All right, so we have a motion by Dr. Dixon and a second by Steve Shell. All in favor, please signify by stating aye.
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 Any in opposition? Or abstention? All right. Let the record reflect that all members present motioned, seconded, and passed to retain our original recommendation. And we will move on to the next recommendation, Kelly.
Actually, we're moving on to the justification, Kelly Marshall for the record, action and research. I will just note that where subcommittee members made a recommendation and provided research, we inserted it. In the absence of any research links or justification, SEI staff did independent research and provided some guidance for you. And so I would call your attention to the justification. And you will note that there are research links provided. There are currently no policy change, funding, legislation, or other action steps noted. So in the initial survey that you used to provide recommendations, it was not accompanied by an action step per se. And so you can see in bold under action step, this is for the subcommittee to develop. So if there are any specific policy changes, funding recommendations, legislation, or other actions that you would suggest to be included in the January report, this would be the place where you could build that out.
Thank you, Kelly. All right, committee members, this is where we roll up our sleeves and do the work. So let's look at the justification pieces. And thank you, SEI team, for putting this research together for us. It's a great launching pad. Are there more refined justifications, I should say, that we want to include? And sorry, Lisa Lee for the record. As a person with lived experience, I just want to say I'm absolutely thrilled about this and do believe that the people closest to the issue are always the people that are closest to the solution. And so I really hope that we can come together as a committee and develop some justifications to that effect, that people that are there dealing with this day in and day out are likely to have solutions that other folks may not even think about. And so I think for me, the justification is relevant and timely information about current substance use trends in communities, because I do feel like it is at the community level that these trends occur. And so I just wanted to throw that out there. All right, I'm going to keep throwing. I'm Lisa Lee for the record. So my first one was relevant and timely information about current trends related to substance use in communities. My second justification would be alignment of services to needs, preferences. I have to think about that. Needs and preferences of the people receiving services. Because I often feel like there's a misalignment between what service providers think people need and what people that are coming into services actually need. And we've seen that in quite a few settings. For example, the living room model, right? Where people with lived experience have really been instrumental in developing sort of a non-clinical, more comfortable place for people to get services that's less scary and intimidating. And so I would say that that's another justification.
This is Dr. Dixon. Are you writing something to add a third justification? Is that what's happening here?
Thank you, Dr. Dixon, for the question. I'm not sure, and I understand. What do you mean? Are we writing something? We as a committee
Well-
are looking for
Well,
additional
I mean, you
justification.
just, right, I know, it, but you put out some language that sounded like a third justification. Is that what you were intending?
Thank you, Dr. Dixon. I'm actually looking at, since SEI came up with these justifications and it's just part of their research, I think, to help facilitate a discussion for us to come up with our justification, since that's work that we have not done yet. So I'm assuming that right now we are doing that work. Is that correct, Kelly?
Kelly Marshall for the record. Right, so you can state as a committee that you want to include both of the justifications written. And then I heard two additional justifications, one around trends and the other around needs and responses that can be designed by persons with lived experience. So what we would do is pull from the transcript and add those as justifications if so directed by the subcommittee.
Thank you, Kelly. Lisa Lee for the record. And now that I wrote them, I'm a way better writer than I am speaker. So I want to say them again for the record. The justification, the first one is critical to providing relevant and timely information on trends related to substance use in the community. And the second one is to ensure alignment of service provisions with the actual needs of persons receiving services, or I should say seeking or receiving services.
Madam Chair, this is Steve Shelf for the record. I think the way you just stated those two items are sound very good to me. I don't have any recommendations to add unless the rest of the committee members do.
Thank you, Steve.
So Kelly Marshall for the record, Madam Chair. So with those two additions, then I think the question would be, are there specific action steps the subcommittee would like to include as well in that report related to policy change, funding, legislation, or other? In other words, guidance on how to implement the recommendation to engage individuals with lived experience in programming design considerations.
Thank you, Kelly. Committee, I'm sorry, Lisa Lee for the record, I do have one more, and that is around diversity and inclusion, given that our LGBTQIA youth and our Black and Brown communities across Nevada, we're seeing some really remarkable trends, not in a good way, related to substance use and overdose. And so I would also, as another justification, add to include diverse perspectives to ensure culturally and linguistically relevant service delivery to people with substance use disorders. I think that's important to call out specifically if the group is in alignment.
Madam Chair, Steve Shelf for the record, I totally agree. I think DEI often gets overlooked in all of this. I think the more we can call attention to that, the better.
Thank you, Steve. Do we have anything further on justifications before we move on to the action? Or how do people feel about the justifications that are currently there on the slide being moved to research links? Or should they be retained?
This Dr. Dixon, they both of them you mean just take them out and put them as just research links?
Correct.
Because
Since
they are.
they're, yeah,
Yeah, because I mean, each of the justifications is linked to one of those research links.
So Kelly Marshall for the record, Madam Chair, I think the thought process from Vice Chair Tolles of the SURG subcommittee was for members who had not participated in this group, that they would see not just the recommendation, but then the justification and supporting research links that evidence that the justification is supported by literature. Where possible, that does not preclude the additions that Chair Lee has made from your lived experience, as well as your professional experience. I would just state that in the report, tonally, you want to make a decision about how much information you provide in the justification for somebody, say a legislator, and this really is dependent on then building out your action steps for whatever audience it is intended, so that they understand, okay, here's the recommendation, here's the justification, there's research to support it, and here are the actions that we would like you to take.
Thank you, Kelly. Lisa Lee for the record. So it has been my experience that with policymakers, brevity is best. So I would move to completely take out this verbose language and retain them in the research links and provide very concise justifications. And I do thank you, SEI, for putting this together, and much respect to William White. I'm always excited to see his work cited. But that would be my recommendation. And I would love to open it up to see what other people's thoughts are there.
Madam Chair, Steve Shelp for the record. I have to agree. I think I would, certainly recommend removing the two current justifications and replacing them with the ones that you've already stated.
Dr. Dixon, what are your thoughts?
I mean, I'm all for adding the ones you have, and maybe finding a good research, a good written reference. But and I agree that they are a little wordy, as most stuff coming out of bureaucracies are. But but I don't know that I would just take them out. But then again, we can't really edit quotes. So it's kind of like, I don't know. I think that maybe I would like to see us move on a little bit to the policy change, because that's what they're looking for us to do. And I have to drive back I'm in San Diego. I'll drive back to Las Vegas today. So I'm hoping we're not too long at this.
Okay, thank you, Dr. Dixon. Point taken. Lisa Lee for the record. I just want to make sure that our justifications are in alignment with our action steps mostly, and don't get lost in the verbosity that we currently have here. It's kind of a lot to take in. However, in the interest of time, we can go ahead and move to our action steps, and maybe that'll help push this forward. Do we have any suggestions there?
Yeah, it's Dr. Dixon again. So I think what I have liked about a lot of committees such as this that have been developed out of legislation is that they have always had at least one or two members are listed, who has to be a member. Membership has to be people with, as you say, lived experiences, family members, former patients, people with experience. And so I would like to kind of make that a policy of committees that are legislatively formed, that they include members that have personal experience with the issues. And like I say, I've seen it done a lot, but I think it should probably be a policy.
Thank you, Dr. Dixon. Lisa Lee for the record. I want to look at that funding piece. I am a firm believer in advisory committees that are filled with a diverse array of people with lived experience, rather than just kind of the tokenized model. Although I am glad that there is inclusion, within statute for many of these councils and committees. However, there is a difference between having your own table and being tokenized, and I just want to call that out. And I also feel that people with lived experience, especially when we're talking about people who are currently using drugs should be, they should be compensated for their time and their experience, just like a professional. So oftentimes people with lived experience are included in these things. However, they're there on their own time and they're not being compensated. Whereas many professionals, including, boards and commissions with many state officials that have been appointed to serve on these councils, they're being compensated for their time. And people with lived experience on many, many occasions are not. And so I think that that's a funding piece that should be considered, that people be compensated for their expertise, their subject matter expertise. Thank you.
I just want to clarify, people like me are never compensated for any of this. So it's true. I think that's one of the real downsides of all of this is that many of these committees are appointees are doing this as part of their job. And for professionals like me, where it's not part of our job, that's why it's a hard time to get professionals to do things that it's not part of they're not salary, it's part of their salary job. And so it's very hard to get physicians and other kinds of behavioral health professionals to do it, to participate. And you'll notice that the attendance of those people, if they're even appointed, is very bad. So I'm not saying I want to be compensated. I don't, but I do think we need to face the reality is that most of our committees are very heavily dominated by state employees who are doing it on their time, their work time. And if I were still in private practice, I would be giving away potential income, but I'm not, so I can do this.
Thank you, Dr. Dixon. That's a really, really important point to consider as well.
In fact, the next actual SURG committee, I had to cancel my clinic because it got scheduled on a time when I have a clinic. And as much as I've asked not to schedule meetings on those 2 mornings, it still was scheduled on one of those mornings. So I am going to lose a morning's salary.
We haven't heard from Chelsea.
Yeah, I mean, I'm just listening to all the other members of the committee. I agree wholeheartedly with the ideas for policy change and the suggestions for funding people with lived experience. And also the suggestion of moving the justifications 1 and 2 to research links, and then including the justifications that you had stated, Lisa. So I'm completely in agreement with the rest of the committee.
Thank you, Chelsea. Well, I don't want to unpack our bags and live in this item. So let's think about action steps. Is there anything else we want to change, or do we want to keep it what Dr. Dixon had proposed around policy change to make it sort of codified that we include people with lived experience in committee membership? I believe that's what I heard, Dr. Dixon, correct me if I'm wrong. And then the second piece about funding, ensuring that people who are not being compensated for their time are compensated, so that we can get people to the table to share their subject matter expertise. Are there any, we didn't talk about legislation. Well, maybe that's the policy change piece that Dr. Dixon was talking about. Are there any other things? Well, hearing none, do we have a motion to do anything with this?
Hi, this is Chelsea for the record. I motion to accept the recommendation to justification action and research. If we are moving the number 1 and number 2 justifications to research links, adding in the 2 suggestions that Lisa Lee had made for the record on for 1 and 2, and then including Dr. Dixon's suggestion for policy change and Lisa Lee and Dr. Dixon's suggestion for funding.
Thank you, Chelsea. I did want to say there were 3 justifications. The last one being to include diverse perspectives to ensure culturally and linguistically relevant service delivery to people with substance use disorders.
Sorry, yes, I amend my motion to include the 3 justifications.
Perfect.
This is not a motion, this is not, well, I'll second it so that we can move forward with the discussion. This is Dr. Dixon. So legislation, I mean, the policy change would probably require legislation, but are we proposing that we want to have a bill draft? And even can we have a bill draft to that effect? I mean,
Thank you for your question, Dr. Dixon. My question to this group would be, is this the hill we want to die on as far as like the bill draft request that we really, really want to make sure that we include, or is there something that we can really make? Is this the change we want to make to ensure that people with lived experience are included in boards and commissions that have like that prescriptive membership through statute? Or is there another bill draft request with any of our other recommendations? So that's the question I would pose to this group. And just to clarify, Lisa Lee, for the record, we had a motion by Chelsea Cheatham, a second by Dr. Dixon, and we are now having our discussion around this.
well, then I will add more. I kind of get the feeling that an agreement that we probably would not want to, if we had one bill draft, this would probably not be what we would want. And I can already hear the arguments against it. So maybe it would not be a good idea to stick with policy. That this is what we recommend policy should be, and not recommend at this point a bill. Although I'm not sure we even have a bill. You know, people don't like mandates, and this would become like a mandate.
Right. So what I'm hearing is, do we need a new motion and second to not include sort of the legislative piece and to focus more on the policy change piece? Is that right?
Kelly Marshall for the record.
Oh.
Oh, sorry.
Kelly
No, go
Marshall.
ahead. Maybe you can clarify this.
Kelly, please.
So Kelly Marshall for the record. Actually, I saw Doug Ward unmute himself, so I was going to ask him.
Sure. For the record, Harry Ward, Deputy Attorney General, my recommendation would be for the motion maker to retract or take back the motion, and then you can have a new motion in second and discussion on that. That would be my recommendation.
Thank you, Mr. Ward.
I'm sorry, this is Chelsea. Just to clarify, I would have to retract my motion. Okay, I retract my motion.
And
For the record, just say your name on the record that you are now retracting your motion, and then Madam Chair can move on for new motions, et cetera, et cetera.
Sure, yes, this is Chelsea Cheatham for the record, and I retract my motion.
thank you, Chelsea. So we're looking to entertain a new motion with everything that Ms. Cheatham said previously, with the exception of that legislative piece.
Sure, this is Chelsea Cheatham for the record, and I motion to approve recommendation to justification, action, and research. Moving the 2 justifications to research links, adding the 3 justifications that Lisa Lee suggested into the justifications, adding the policy change suggestion that Leslie Dixon mentioned, as well as the funding suggestions that Lisa Lee and Leslie Dixon mentioned, and removing the legislation action step.
Thank you, Chelsea. We have a motion.
Oh, I second it again. Dr.
And-
Dixon.
Dr. Dixon seconds. All right. All in favor, please signify by stating aye.
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 Aye. You know what? Do we need to have discussion, any further discussion before we go to a vote?
For the record, Madam Chair, you might as well, even though this has been discussed and we knew that this was the progression of the new motion. So yes, my suggestion, open up briefly before we have the final vote.
Thank you, Mr. Ward. Do we have any further discussion on this before we move towards a vote? Well, hearing none, all in favor, please signify by stating aye.
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 Are there any in opposition? And no abstentions? All right, all members present voted unanimously to pass the justification, action, steps, and research links for this recommendation. Kelly, we'll move on to the next one.
Right, Kelly Marshall for the record. So the third recommendation you had was to implement follow-ups and referrals to support and care, linkage of care for justice involved individuals and pregnant or birthing persons with opioid use disorder. It was noted at the October 3rd SURG meeting that this recommendation could include or correlate with individuals leaving the justice system. So I think there was a question about whether linkage of care for justice involved individuals should more explicitly state, including individuals leaving the justice system, or if it were to be assumed that linkage of care for justice involved individuals would include those leaving the justice system. So no other subcommittee has brought forward a recommendation specific to this. It does correlate with the response subcommittee.
Thank you, Kelly. Lisa Lee, for the record, do we have any discussion around this one?
Chelsea Cheatham for the record. I believe that we could change it to implement follow-ups and referrals to support and care, linkage of care for justice involved individuals, including individuals leaving the justice system, and pregnant or birthing persons with opioid use disorder. I think the clarification would just make it easier for everyone to know what we meant by this recommendation.
Thank you, Chelsea. And any further recommendations on amending that language? All right, well, hearing none, Is there a motion to approve the recommended language change for this, this particular recommendation?
Madam Chair, this is Steve Hill for the
I'll make
record.
this-
Oh.
Good. Go.
Oh, we
Steve.
have Steve.
Thank you, Dr.
Go ahead,
Dixon.
Steve.
I make a motion to amend our recommendation to include individuals leaving the justice system as stated by Chelsea Cheatham.
Thank you, Steve. We have a motion.
Dr. Dixon, I'll second that.
We have a motion and a second. Any further discussion on this item? All right, all in favor of moving forward with the recommended language addition, please signify by stating aye.
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 Any in opposition? Any? All right, we're going to move on because all members present voted unanimously to pass this recommendation. Here we go.
Kelly Marshall for the record. So again, the justification provided has the research links below. And what we're hoping for is any changes or additions to the justification, any additional research links you would like to provide, but primarily any development of policy changes, funding, legislation, or other. And I will just go back. So this is for this recommendation, which has now been revised to say linkage of care for justice involved individuals, including individuals leaving the criminal or the justice system, excuse me.
Thank you, Kelly. Do we have any recommendations for language for justification? I'm going to jump in. Lisa Lee for the record. I would ask the group about the possibility of including the language, or I should say borrowing the language or repeating the language that we had for the justification for the recommendation 1. And it reads, improve, I would say, survival outcomes instead of patient survival. Improve survival outcomes, increase retention in treatment, decrease illicit opiate use and other criminal activity among people with substance use disorders. And then the next one, number 4, would be improve birth outcomes among pregnant and birthing persons. I noticed that the first one has women in it. I would not use that word because not everyone who gives birth or is pregnant identifies as a woman. So I would say improve birth outcomes among pregnant and birthing persons as my 4th recommendation for justification, just borrowing some of the language from that first one. And I'm open to the floor for any recommendations for justification.
The only, this is Chelsea Cheatham for the record. The only thing that I think is missing from the justification, because with your addition, Lisa, we're adding a justification for pregnant and birthing persons. There's one for justice involved individuals following release, but nothing for current justice involved individuals in the justification. I don't have any suggestions on what we could put there, but I think it would be great for us to have a justification specific for people that are currently involved in the justice system.
Thank you, Chelsea. That's a great insight about that. What about increase, I think the increased retention or increased engagement? For justice involved individuals, including during incarceration and reentry. Would something like that make sense?
Yes, Chelsea Cheatham for the record. I think that's perfect.
Lisa Lee for the record, I would again ask committee members what they think about moving the justification pieces to, again, it looks like they're already down at the research links, but getting rid of, you know, the kind of verbose language there. Again, thinking about our audience.
Chelsea Cheatham for the record. Lisa, are you suggesting that we move all of the justifications down to the research links, or keep maybe 3 justifications that are specific to this recommendation in justifications and then move everything else to research links?
Thank you, Chelsea. I guess to clarify what I meant by that is the current justifications that SCI put together for us based on the research that they've conducted. They're all quotes, and they're pretty verbose. And yes, they do support, they play that supportive role with justifications. But again, my experience with policymakers is they'll see all of this text and they will not read it. And so just to, you know, in the spirit of brevity, I think just bullet pointed, very brief summaries of what we're trying to say in those justification pieces would be my recommendation for anybody to actually read this and absorb it.
This is Dr. Dixon. I'm not sure I know where all this is going. When you say legislators reading, who is going to be reading all this? I mean, who are we aiming this at? Is this part of our report, or is this something that's going to go directly to legislators?
Kelly Marshall for the record. So I would need to pull up the legislation. Ashley, I don't know if you're able to do that. The report in different years goes to different bodies. So it has different audiences for legislative session years than it does for non-legislative session years. But what I would say is it goes to policymakers in general. And I believe will also be used to inform the legislature as appropriate should bills come up that link to recommendations made in this in the report to be completed and approved in January. And I can try and pull up the legislation and read the language specifically if you give me a moment.
Thank you, Kelly. Lisa Lee for the record. I want to say that there's like even in odd years, and one goes to the governor's office and one goes to the Legislative Council Bureau or the LCB, but I can't remember if it's to the governor's office or to the AG's office for this one. But I want to say, if you could pull that up, that would be great. I believe it's the governor's office and the LCB. I know the LCB is one of those entities that receives that report.
Put that one back.
And Kelly, This is Lee for the record. I want to state that we have our chair in the House. I see Assemblywoman Thomas. Assemblywoman, did you want to chair the meeting from here?
Yes, I can.
Perfect.
Can
I
you
will
hear
turn
me?
it over to you. Yes, ma'am.
All right, thank you. Thank you, everyone, for being present. Thank you, Lisa, for chairing. I do appreciate it. Just got back on. Thank you so much. But if you could just bring me up to, go on to what you were doing, because I believe you were in the middle of something.
Yes, Madam Chair. So just to give a brief overview of what the business we've conducted so far, we have been looking at our subcommittee recommendations, sort of merging some of them or not merging them based on what the recommendations were from the SURG meeting. And then now we're also working on those justification, action steps, and research links that's in support of our justification and action steps, and ensuring that there's alignment and continuity across them. And right now we were just discussing who is our intended audience for this and where do those reports go. So I believe Kelly was pulling up, I can't remember if it's AB or SB 374, to sort of see where the, who gets the reports, who's on the receiving end. I want to say it's the governor in 1 year and the LCB in another year, but that's kind of where we are right now. Thank you, Chair Thomas.
All right, thank you. And thank you, Kelly. If you could proceed with what you have as far as any changes in the policy, if I'm understanding it correctly.
Yeah, so thank you, Kelly Marshall, for the record. So Madam Chair, we are on recommendation 3. We have approved recommendation 3 with a slight revision. We're now discussing justification, action steps, and research links to go into the report. I am in the process of trying to pull up the legislation to explicitly note who the report goes to in which years. So I'm working on that, but in the interim, the suggestion, I think what would be simplest is to go backwards. The recommendation was to include a revision of this justification with an addition specifically for improved birthing outcomes among pregnant and birthing persons as one of the this treatment approach or this intervention has been shown to improve patient survival, increase retention in treatment, decrease, and I'm not sure of the language. I would have to go back to the transcript, which I don't have right now. But for D, I think that would change to improving birthing outcomes. And then there was a question from the committee about who the report goes to, because they're trying to craft language that is digestible for the audience. So we want to just be sure about the audience. And so if you give me a moment, I'm just sorting through a number of old files to try and get to the right document. I do believe in this case, so I'll take us back to where we are. We are here, that there could be a discussion specifically about whether there is any policy change, funding, legislation, or other action steps that the subcommittee would like to include along with the justification and the research links for this recommendation. But I think they're waiting to find out who is the audience. And so I'm sorry that I am the bottleneck on this right now.
Madam Chair.
It looks like I am in an unstable area. Can you hear me?
Yes, Madam Chair, would you like Ms. Lee to continue until you get to a
I
stable
think that
area?
would be,
Kelly
yes,
Marshall.
I
for the
think
record.
that would be, yes. Ms. Lee, if you could continue in the meeting, and when I hopefully get in a more stable area, I can rejoin, okay?
Okay, thank you,
Can you hear
Madam
me?
Chair.
Thank-
Yes.
Thank you.
Lisa Lee, for the record, I do have that pulled up, Kelly. I'm looking at the conceptual amendment, though. I was going to then cross-reference it with as enrolled. But it does say submit the report to the governor, the attorney general, the advisory commission on the administration of justice, and any other entities deemed appropriate by the attorney general and the director of the legislative council bureau for transmittal to during an even numbered year, the LCB on healthcare, and during an odd numbered year, the next regular session of the legislature. So just to confirm, we are talking to policymakers who are definitely not going to read through a bunch of verbose language. Does that help, Kelly?
So this is Dr. Dixon. I'm very sorry I raised this question. So anyway, I don't find these justifications so problematic. They're fairly simple, and if we're talking legislators, we're going to have a lot of brand new legislators that aren't going to know much of anything about the issues. And so I think these simple justifications probably ought to stay there in a recommendation that's this important as referral into treatment.
Thank you, Dr. Dixon. So just to clarify what I'm hearing from you, you're recommending that we retain these justifications as they are?
Well, I'm not saying as they are, but I don't think we ought to move them down to research and take them away. If they want to make some change, little changes, yeah, because I think there was an issue with one of them, but I would not eliminate them.
Okay, so let's put out recommended language or recommended edits on those, if you could, Dr. Dixon.
Well, I think there was a concern about the third one with the release from incarceration, and that we needed to add something in there about those that are still in an incarcerated situation, or actually it could be also incarceration and things like drug specialty courts, because they're still part of the justice system when they're in the specialty courts.
Thank you, Dr. Dixon. I believe there was a justification proposed. I can't remember exactly what I said, but engagement of people who are currently, wait, hold on, let me pull up my notes here. Engagements, I didn't write it down, see, so I'll never remember it. Lisa Lee, for the record, it was increase engagement with currently incarcerated persons and re-entering persons, something to that effect. We'll have to check the minutes for that one. Does that sound right, Chelsea?
Yes, Chelsea Cheatham for the record, that sounds right.
And Dr. Dixon, I think there's an opportunity to also include in people with continuing engagement with the justice system, to just be inclusive of all the ways in which people are kind of involved. would that be helpful, Dr. Dixon?
Yeah, yeah. Because that can go on for, I guess some of those specialty courts, they're in them for 2-3 years. So,
Any further discussion on sort of the logic of brevity versus keeping the current recommendations also and just adding to them? Is there any preference either way?
Chelsea Cheatham for the record. I support the idea of keeping this as brief as possible and in moving the other justifications that to research links. That way the information can still be researched and looked up, but having the justifications focus on the populations that we were focusing on in the recommendation. So the suggested justifications.
Thank you, Chelsea. And how are we feeling about moving on to our action steps? I'm looking at the clock here. All right, let's open it up for discussion around the action steps here. Do we want to retain those, add to them, delete them?
Madam Chair, this is Steve Shell for the record. I think for this particular recommendation, I think we should leave legislation as one of the action steps to require the jurisdictions to have to provide these programs. So that would be my recommendation here on those. And I'm fine with the other action steps as listed.
Thank you, Steve. Lisa Lee, for the record, I would advise to remove other unless we're specific about what other means.
Kelly Marshall for the record. So those placeholders were provided as placeholders for you. Anything that does not include an action step will be removed from the report.
Thank you, Kelly. Lisa Lee, for the record, in that case, my other would be to ensure that local jails, our Nevada Department of Corrections and specialty courts are in conversation with one another to ensure, like, where's the accountability piece on that, where the rubber meets the road with the implementation? Is there an opportunity for us to get strategic around ensuring that there's continuing dialogue within kind of our justice system in Nevada? So there's continuity in creating this comprehensive safety net for justice involved folks. I would make the same recommendations for our child welfare and medical providers that treat pregnant and birthing persons with substance use disorders, to ensure that, again, there's continuity across systems. If anyone has any thoughts on that. Or we can entertain any motions around what we've discussed as well.
So, Madam Chair, this is Steve Shell for the record. So I agree with you about including that engagement. I could see that falling under policy and legislation. Do you think we need to specifically state that here? Probably so, but
Thank you, Steve, for the question. Lisa Lee for the record. I would be specific, policy change that includes considerations of system continuity and collaboration in the justice system and child welfare and provider system. I would include specific language around that because I think policy changes, I mean, you know, what does that mean? I think that policymakers want specifics that they can sort of sink their teeth into and not have to read between the lines, has been my experience.
Steve Shell for the record, I think that's perfectly stated. So that would be my recommendation, that we add that exact language to the policy change step.
Thank you, Steve. And if there's no further recommendations, are there any motions on this one?
Hi, this is Chelsea Cheatham for the record. I motion to approve the recommendation 3, justification, action, and research, with the changes to the justification section, as well as the changes to the action steps as discussed by this subcommittee.
Steve Shell for the record, I will second.
We have a motion from Chelsea and a second from Steve. And some barking. I thought we were going to get a second from from some doggies. Any further discussion on this item? All right, let's go ahead and put it towards a vote. All in favor of accepting this, the justification, action steps, and research for recommendation 3 as proposed by Chelsea, please signify by stating aye.
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 Any in opposition? I don't see any abstentions. All members present voted unanimously to approve this. We'll move on to the next one. These are meaty. Go ahead, Kelly.
Okay, thank you, Kelly Marshall for the record. So your 4th recommendation included implementing changes with an asterisk to recruitment, retention, and compensation of state frontline healthcare workers and enhanced compensation in alignment with the Commission on Behavioral Health Board's letter to the governor of June 22nd. So there is that request to see the October 3rd attachment with the highlighted Commission on Behavioral Health draft letter to the governor dated June 23rd, 2022 for details on the changes. So rather than outlining all of those, we highlighted Northern Regional Behavioral Health Policy Board, Clark County Behavioral Health Policy Board, and then the Commission's recommendations, and you included them all in total. The Prevention Subcommittee recommendation from October 12th and their subcommittee meeting said to continue to sustain and expand investment in community health workers, peer recovery specialists, and certified prevention specialists throughout Nevada. And they noted support for the Joint Interim Standing Committee on HHS bill draft request number 333, which revises provisions relating to community health workers. I would note that I believe that their recommendation covers the compensation component, but does not cover the recruitment and retention component. So I think your options are to either revise your recommendation, leave it as it is, blend it with prevention if you so desire, or revise it in some other way.
Thank you, Kelly. Lisa Lee, for the record, I do want to say that we did have a similar recommendation around community health workers, peer recovery support specialists, and certified prevention specialists that I recommended. However, I did have a conflict of interest that I will again state for the record here, that I serve on the Nevada Certification Board, and we provide certification and renewals to all of the aforementioned certifications in that prevention subcommittee recommendation, and also doulas in the state. So I do want to state that for the record. It does align with that recommendation that we had up. And we'll open it up to discussion if we'd like to retain our original recommendation or amend it to sort of include the language of the prevention subcommittee's recommendation.
All right, this is Dr. Dixon. I would add at the end, after June 22nd, of our, what we have is to add what they have recommended, say additionally, comma, continue, blah, 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 to our recommendation.
Thank you, Dr. Dixon, for that recommendation of additional language. Other committee members, what say you?
And Chelsea Cheatham for the record. My suggestion is to combine these two because they are pretty similar. I think we can combine them by saying continue to sustain and expand investment in the list by implementing changes to recruitment, retention, and compensation. So just maybe move this prevention subcommittee sentence to the front of that of our recommendation.
Thank you, Chelsea. So we now have a recommendation to include it at the front or include it at the end of the current sentence. Steve, do you have a preference?
No, Madam Chair, this is Steve Shell. I would agree with Chelsea and Dr. Dixon about possibly combining these two.
And any preference on where it goes?
No.
Okay. Well, Lisa Lee, for the record, I'll throw in my 2 cents. I don't want other frontline healthcare or behavioral health workers to assume that our entire recommendation is based around sort of paraprofessional certifications and be upset with us. So I want to be considerate of sort of all the ways in which people work in this space, including licensed clinicians, including medical doctors, including nurse practitioners, et cetera. How can we, or is our intention to be inclusive of state frontline healthcare workers? Or do we want to just pour eggs kind of in this non-clinical paraprofessional basket? Because I do think it matters then where we place this sentence with kind of how that meaning is constructed.
This is Dr. Dixon. I I'm going to, like I already said, I kind of prefer it in as a second sentence, the addition, but the word state bothers me. Are we just, is this, I don't want it to imply that we're talking about state employees, because there's actually very few healthcare providers are state employees and almost none in substance abuse. So I'm a little, is there's a way to say, and the other thing is in a lot of telemental health, telepsychiatry, whatever you want to call it, is actually being done now by people not even living in the state. They're doing it from elsewhere. If they have Nevada licenses in order to do it to our citizens or residents, I should say. But in fact, some of our people that used to live here have moved to other states and are still doing telemedicine to our people. And so that I'm like I say, I'm a little concerned about the word state. Should it be expanded on? Should it be? I don't know. I don't know what to say. I'm just saying that we don't want it to be assumed to be state employees, because that's just no good.
Thank you, Dr. Dixon. I would agree with you that we should pull the word state unless we're meaning state employees. And I would also add frontline healthcare. I would also add health/behavioral health to be inclusive again of all the ways in which people work in this space. That it's not just this medicalized model, but there are a variety of different treatment delivery settings that include behavioral health, or it could include like traditional, medicalized health. And I would also state that if we're looking to be inclusive of, again, like all behavioral health and healthcare providers, and also these non-clinical paraprofessional certifications, then I think that the prevention subcommittee recommendation would be added to the end if we want that inclusivity. If we're just focusing on these non-clinical paraprofessional certifications, then it would be the leading sentence. And correct me if I'm wrong, but that's how I understand the language to be. We want to be intentional around this. So, Kelly, please.
Okay, Kelly Marshall for the record. So why I brought up the draft letter referenced in this recommendation is that it is more expensive than just community health workers, peer recovery specialists, and certified prevention specialists. It had a workforce component, it had a retention component, and it included both health and behavioral health.
Great, thank you, Kelly. So it would be my recommendation to remove the word state, to retain frontline health / behavioral health care workers and enhance compensation, blah, 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 blah. And then again, as Dr. Dixon recommended, after June 22nd, comma, continue to, and then add that recommendation. So I just want to throw that out there. I'm in alignment with Dr. Dixon.
The only thing I'd say differently is to leave the period, use a word like additionally, and then comma, and then, because otherwise you're getting such a long sentence, which someone who has to read things out loud, you don't like to have too many long sentences.
Lisa Lee, for the record, I would agree with that recommendation. Are there any other recommendations? So we kind of had two things on the table. One is to have that, the prevention subcommittee recommendation be that leading sentence. And the second recommendation is have it be sort of an additional sentence using such a word as additionally or furthermore, blah, 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 continue to sustain. And then we can move forward if anyone has a motion or any other further discussion on this.
Do you want me to turn it into a motion or is it already a motion?
I'm looking for a motion. As a chair, I can't make a motion.
All right, I'll make this is Dr. Dixon, I'll make the motion. Take out the word state in the first sentence and just leave healthcare / how do you say it? See, healthcare, health and behavioral healthcare workers in that sentence, and then at the end of the first sentence after June 22nd period, bring up the prevention recommendation with something additionally or furthermore, either word works for me, comma, continue to sustain, and then the rest of that. That would be my motion. Not the clearest motion in the world, but still would be my motion.
Thank you, Dr. Dixon.
And Chelsea Cheatham, for the record, I second that motion.
We have a motion from Dr. Dixon and a second by Chelsea Cheatham.
Madam Chair, just
Do
for the
we
record,
have any
Harry
further
Ward, Deputy Attorney
discussion?
General, I know that you've made a disclosure earlier, but it is also my understanding that based on your disclosure, you can still be fair and impartial in this matter. And I think you should say that on the record, my suggestion, before a vote is taken, if it involves a vote in this matter.
Thank you, Mr. Ward. So you're not advising that I abstain? Okay, so I will state
For the record, Harry Ward, I'm not advising you to abstain. As long as you can still say I've made my disclosure, I still think I can be fair and impartial in this matter, and we can continue, and that's all we need from you, ma'am.
Okay, thank you, Mr. Ward. Lisa Lee, for the record, I do sit on that Nevada Certification Board, but I do believe in inclusive language, and I don't have anything to gain on this. It's totally a voluntary, process. And so I do believe that I can be fair and impartial in my vote today. Do we have any further discussion before we bring this to a vote? All right, hearing none, all in favor, please signify by stating aye.
Aye.
Aye. Any in opposition? Any abstentions? All right, all members present voted to approve this item unanimously, this recommendation. Before we move on, Kelly, I did want to take a clock check here. It is 11 a.m. I believe this meeting was scheduled until 10:30. And so I'm wondering, we do have quite a few more recommendations to go through, as well as the justification, action steps, and research links. I'm a little concerned that we're going to be doing this for a long, long time. And I'm wondering if we can table these items for our next, add them to the next agenda and move forward with what we've had so far. And, just out of respect for the professionals on the phone's time and Dr. Dixon's long drive today, if we could move on to agenda item number 5, if that would be okay.
Kelly Marshall, for the record, I don't believe that we have another meeting scheduled, so we would need to schedule a follow-up meeting. For that, I think the next meeting was going to be a full SURG meeting. So if the chair is directing us to establish another meeting that's consistent with the wishes of the subcommittee, then SEI can work to do that.
Thank you, Kelly. And do we have our actual chair of this committee on? Do you see Assemblywoman Thomas? I'm not comfortable in making that call as I'm just filling in.
I don't think she's on.
No, so Kelly Marshall, for the record, I will just note that I had a discussion with Chair Thomas yesterday, and she did indicate agreement with the idea of a shorter meeting if needed to complete this work.
Thank you, Kelly. Lisa Lee, for the record, I would love that, because I think if this was the only agenda item in addition to the public comment periods, that would be great. This is a pretty robust agenda, and so I want to make sure that we get to the end.
And Kelly Marshall, for the record, this PowerPoint will be posted to the website along with the meeting agenda and the minutes from the previous meeting, which are already posted. So this will be an additional posting. And so the subcommittee could review the PowerPoint and see what slides were coming up next and come prepared to the next meeting with any action items or justifications or research links that they wanted to add that might facilitate a quicker meeting.
Perfect. Thank you, Lisa Lee, for the record. So I believe what you're saying is do your homework and come prepared for class. right.
I do want to make a comment about that. You know, I mean, we got the date for this meeting a month ago. I put it in my calendar, and then we didn't hear anything more until yesterday. So maybe a reminder somewhere in there would be good, because then I had to search around. I had to make sure there really was a meeting. And so yeah, so I'd appreciate maybe a little more in between meetings.
Thank you, Dr. Dixon. All right, we're going to go ahead and move on to agenda item number 5, because this is important work that needs to be done this meeting. So I just want to start out that section 7E of the SURG bylaws state that the subcommittee members will serve for 1 year on the subcommittee. After 1 year, the working group chair will determine if the subcommittee needs to continue for another year. I'm not here to make that decision today, but I will read on. If the committee is needed for another year, the working group chair will appoint the subcommittee chair and members from the working group. So in order to get a sense of who wants to remain on this committee or move on to another subcommittee, this agenda item is being included for all subcommittees to discuss. And so I think the ask here today is if you want to stay on the treatment and recovery subcommittee or move to another one like the prevention subcommittee or the response subcommittee, or are interested in a chair or vice chair subcommittee appointment, we are here to talk about that today. So I'll open up the floor. And I'm going to ask a question. Lisa Lee, for the record. I have a question before we engage in this process. So it has been very, very confusing about where harm reduction fits in. And there was discussion around, would there be another committee to just work on harm reduction recommendations? And it seems to me as a committee member that talks about harm reduction have recommendations have been brought up by every single one of our committees, but it also simultaneously feels like those have been quashed in every single one of these spaces because no one really knows where to put it, right? It doesn't quite belong in prevention. It doesn't quite belong in treatment. It doesn't quite fit in response. So does it fit into its own committee? I think we're still undecided about that. I just want to mention that here in today's meeting. And the other piece is, I think what I understood, and I had to attend the Acorn to really understand what was going on because it wasn't clear in the surge. In the Acorn, I did hear Terry Kearns talk about maybe all of the committees would come together and flesh out those harm reduction recommendations. But I don't think we really have a for sure process around this. And so I guess what I'm looking for is clarification if anyone has any. Thank you.
Madam Chair, for the record, Kelly Marshall. So my understanding is that one of the subcommittees explicitly pulled out harm reduction recommendations and made them in addition to their subcommittee recommendations. Medication assisted treatment, or our MAT recommendation, our #1 recommendation, was also referenced in a harm reduction recommendation from another subcommittee. That was the prevention subcommittee. That was the first recommendation that we looked at today. And so my understanding is that it's organically evolving for this report, that there will be recommendations there will be general recommendations, and they will include harm reduction recommendations. So recommendations will not be assigned or ascribed to any particular subcommittee. They will be adopted by the entire SURG for this report. As to whether there will be another harm reduction subcommittee added, you know, I am not aware of any definitive action taken on that. I think that's something that will be agendized for a later SURG committee meeting prior to adoption of this report in January. But I don't believe that your #1 recommendation, which could be considered harm reduction, will be excluded from that report. It may be organized under harm reduction as a special category. But once the decision was made to not present subcommittee recommendations under headings of prevention, treatment, and recovery and response, but to put them into categories such as workforce, right? Data, for example. I don't have all the headers figured out because we're working across 3 subcommittees, but that's my understanding of how they will appear in the report. And you will see the report in draft prior to its adoption in January. So I don't know if that clarifies anything for you, but that is the best information I can provide at this point.
Okay, thank you, Kelly. Lisa Lee for the record. So what I'm hearing is, as of this time, because it does pertain to this conversation, right? If people, would they want to duly serve on this committee and a harm reduction committee, should one, be formed? So it does pertain to this conversation. So I guess what we're looking for today is kind of the appetite from all, committee members. If you'd like to remain on this committee, or if you feel like you maybe, fit better in one of the other committees. So again, those committees are the prevention subcommittee and the response subcommittee currently.
Chelsea Cheatham for the record. As the harm reduction representative on the SURG, I don't know. I'm just kind of hearing everything today, and then and not really knowing where harm reduction is going to fall. I don't really know which subcommittee is the best one for me. I would like to be on one that is focused on harm reduction recommendations. And if it's going to be a separate subcommittee, I would like to be on that subcommittee. If all of the groups are getting together, I'm not sure if that's going to happen. If all the subcommittees are getting together to make harm reduction recommendations, I'm not sure. I didn't think I understood that, but I did at the last SURG meeting. That's what I understood was going to happen, but I'm not sure if that's still going to happen.
Thank you, Chelsea.
So Kelly Marshall for the record. Madam Chair, my understanding is that when all subcommittees get together, that is a SURG meeting. So that could be agendized as a topic at a SURG meeting because all of the members, with the exception, I think, of 1 or 2 people who have been appointed in the interim, serve on a subcommittee.
Thank you, Kelly. And any other folks, is there, would you like to remain on this subcommittee?
Well, it's Dr. Dixon. I think this is where I belong. So, since that's what I do.
Thank you, Dr. Dixon.
This is Steve Shell for the record. I agree. I think this is where I belong as well. So
Okay, perfect. Two ones find belonging in this home of treatment and recovery. Lisa Lee, for the record, I'm going to throw my 2 cents in. I align with Chelsea as someone who harm reduction has been a center of my life for the last 28 years. I really would be interested in serving on the harm reduction committee should one form, but the closest thing to it, I think I belong here. I definitely belong on the recovery side. And so I'm interested in continuing to serve on this committee. And what about you, Chelsea? Would you be interested in remaining?
Yes, I'm interested in remaining on this subcommittee.
There you go.
Perfect. And so I guess the next ask is anyone interested in being a chair or vice chair for this subcommittee?
Madam Chair, Steve Shell for the record. Is this where we can nominate you for one of the roles?
I think there's a consensual process to nomination. We could also leave this up for discussion on a later agenda if we're going to meet again, on those other recommendations. We can figure out the chair piece, I think, going forward. If everybody's comfortable with that, we can let it stew. Maybe we want to take this on, maybe we don't. We can confer with our colleagues. Is that okay? All right, so just to clarify and wrap up this agenda item, I'm hearing from all members present here today, including Dr. Dixon, Steve Shell, and Chelsea Cheatham, and myself, Lisa Lee, that we are all interested in continuing to serve on this committee. And I think this requires no vote. We just all gave our consent. And so we can move on to our second public comment period. Just a reminder that via Zoom, the rules are still the same. It shall be limited to 3 minutes per person. And no action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included on an agenda item upon which action may be taken pursuant to Nevada Revised Statutes 241.020. And so if you would like to speak in public comment today, please go ahead and raise your hand so that we see you, and unmute your mic, state your name for the record. Thank you.
Madam Chair, I do not see any raised hands, and I'm looking to see if anybody would like to unmute themselves to make public comment. I do not see any members unmuting themselves.
All right. I just want to thank everyone for your continued participation today. I know that we got through some rough pieces together and we really moved forward, and I'm looking forward to the next meeting where we roll up our sleeves again. This meeting is adjourned. Thanks, everyone. Have a great
Thank
week.
you.
Thank you.
Bye.
Bye.
All right, thanks, guys.
Bye.
Thank you, Dag Ward.
Thank you.